Hi, everyone. Thank you for joining us this early evening with a great webinar by Dr. Alex Vaccaro on lumbar spinal stenosis. Dr. Vaccaro needs no introduction, but he is our spine surgeon here at Rothman Orthopadiecs, seeing patients at our Center City and South Philadelphia offices. Dr. Vaccaro is also the president at Rothman. So please enjoy the presentation. If you are new, you may not know, but we do have a Q&A box at the bottom of our screen. If you are a frequent flyer to our webinars, then you know the drill, but please feel free to enter your questions in that box, and Dr. Vaccaro will take about 10 minutes to answer as many questions as possible at the end. You can take it from here, Dr. Vaccaro.
Thanks, Natalie. It's a joy, a pleasure, and an honor to be able to talk about a different topic every 3 months. So, what we do is we choose the most common problems in spine surgery. And we talked in the past about cervical disc herniation, cervical stenosis. We'll talk about scoliosis. We'll talk about spinal stenosis. Lumbar spinal stenosis is one of the most frequent problems that I encounter, and it's something that we encounter as we age. So it's interesting. What stenosis just means is narrowing. So the canal narrows. You could have cervical stenosis, you could have thoracic stenosis, you could have lumbar stenosis, and each region of the spine presents clinically differently. The most common presentation for lumbar spinal stenosis is as you get older, I start seeing it 50-year-olds, 55-year-olds, 65-year-olds, and then the most frequent is in patients in their 70s. They come in. As you get older, you begin to develop arthritis. You begin to develop like what I call occult instability. You'll develop a degenerative scoliosis. You may develop a spondylolisthesis, and the body doesn't like that, so the body tries to stabilize itself. So as the discs begin to generate, the joints begin to get bigger, like you see in your fingers and your knees. But unfortunately, in the spine, it crowds the nerves. And when it crowds the nerves, you begin to develop symptoms. So if you look at this little picture down below, that's the L45 level. And you see in the very center, and I don't know if you can see my arrow, maybe you can or you can't. That's where the nerves live. And these are the joints. This is called the superior portion of the joint of the vertebral body below L5. This is the inferior joint or articular process of L4. And as you begin to develop aging and arthritis, these get larger. And see what happens when it gets larger? You can't see your nerves anymore. So you go from this side picture, the sagittal, which is the third picture from the left, where you can see the white, that's where the nerves live. And then all of a sudden, the discs begin to bulge because they collapse. The ligamentum flavum, which is the soft tissues in the back, begin to buckle in. The joints get larger. And all of a sudden, you're miserable. You're having a hard time walking. And so, it's interesting. So the term stenosis comes from the Greek word meaning choking, and it's basically chokes off the nerve. So this is a typical example, and I'll show you what I see almost every week in the office. A middle-aged individual comes in and says, my legs are getting heavy. It's becoming difficult to walk. I have to sit down. I have to bend forward. So we all use terms like the positive shopping cart sign. And the only thing that we as surgeons have to differentiate about is this due to neurogenic claudication, which is pressure on the nerves, or is it due to vascular, like you don't have good vascular supply? So if you have adequate vascular supply, as you sit down, you can differentiate by having someone sit on a bicycle and ride a bicycle and a stationary bicycle. If they have vascular problems, their legs are going to hurt. But if they have spinal stenosis, when they flex their spine, the amount of space gets bigger. So that's what happens. So this is a perfect example. Is a person, there's no instability, there's no deformity, and you can see L5S1 down below, plenty of room, L45 above, and that's a headache. So then I have to begin a whole treatment cascade to try to make this patient feel better, which is interesting. So as I said before, you start to get into degeneration, the disc collapse, the disc bulges, the joints get larger, the ligament flavum, which is a yellow ligament, bulges in, and then all of a sudden you have stenosis. And there's in the middle, it's called central. As you get to the sides, it's called lateral recess, and as you go out where the nerves are, it's called foraminal stenosis. So the most common presentation, patients say, listen, I got this numbness that gets worse as I walk. I have to stop, I have to sit down, or I have to bend forward, and then the numbness abates. And then I start walking again. My legs feel heavy, but they say the classic things. When I bend forward, when I sit down, I feel better. And it's interesting. These patients rarely ever have, when you see them in the office, you can't pick up any abnormal findings. You can't pick up any weakness. They may or may not have numbness in the office, but the exam is like normal all the time because it's only a dynamic process. When they walk, the nerves get crushed, they feel miserable, they stop walking, they bend forward. So the exam could be perfectly normal. And this is just a typical example. Standing up straight narrows the canal. You're miserable. That's why you see older people bending forward because it feels more comfortable when they bend forward. So classic neurogenic claudication. Here's an example of it. You could see the spine in extension, and you could see the spine in flexion. And if you go to the right of those pictures, the anatomy, when you extend, you can see that redness. The space gets smaller, and then when you flex forward, it opens up. So now everyone understands like why we have our symptoms when we have spinal stenosis. So you're thinking to yourself, well, what can I do non-operatively to feel better? Can I increase the capacity of the canal? And then if I don't get better, what can I do surgically to increase the capacity of the canal? So that's how we look at it. So today I never get a myelogram CAT scan. That's torture, sticking a needle in someone's back. I only do it when I have to, but I do everything I can not to. And I probably see 100 patients a week. I can't tell you the last time I ordered a myelogram CAT scan. We tend to order it if there's a lot of metal in the spine, the MRI, there's a lot of artifact, but usually you can figure it out. Usually they use these suppression imaging in radiology now where they can sort of subtract the metal and minimize the artifact. So the key thing is the Venn diagram. You want to listen to the symptoms, you want to examine the patient, and then you want to get the imaging studies. When they all overlap in the middle, that's the Venn diagram. And that patient is a typical example of someone with stenosis. And they usually do well. 70 to 80% of people will do great with non-operative treatment. um, get their core strong, have them lose weight, intermittent anti-inflammatories. Very rarely do you have to give, I never give narcotics. The big craze now is gabapentin, which you can use, but I just think anti-inflammatories and Tylenol, they do well. Do epidural steroids work? 60% of the time, they work. 40% of the time, they don't. If you have severe pathology, they work less well. But you want to get them in the physical therapy. You want to condition the body to move along. And 70, 80% of the time, when someone's symptomatic, this is all you need to do. Very rarely do you have to intervene. And we only intervene if people are miserable. They just not comfortable. They can't do the things they want. They start limiting what they want to do. And that's the saddest thing is when someone's really nervous about spine surgery, their family brings them in and they go, I don't have any pain. I feel great. And they go, Mom, you don't walk anymore. Because if she's not walking anymore, she's sitting in a chair, she doesn't have any symptoms. And then they get heavy and they get heart disease. So it's a functional problem. And if they fail 3 to 6 months of non-operative treatment, we start to consider surgery. And you always think this way. You always think, is there an instability? And what's the most minimally invasive thing I can do? Can I use an endoscope? Can I use a tube? Can I do a laminopharaminotomy? And you think about what is the least amount of invasiveness you can do to make someone's legs feel better. But if they have instability, you may have to deal with that because if you remove anatomy and make it more unstable. And I put this little thing down, interspinous process, and I'll show you a few examples, which is interesting. Interspinous process is something some gentleman invented it from France. It goes between the spinous processes and sort of elevates it. So it sort of flexes the interspace. And I said before, flexing is good. So there was a craze that we used it. It doesn't work as well as we thought it worked, so it's losing favor. But we have all sorts of procedures. The anesthesiologists do something called the mild procedure, where they put like a little wire in and they sort of, rotor it back and forth. Interspinous process spacers, bumpers that you could put between the spinous processes. But the bottom line here is you probably don't have to put anything in the spine. You just have to take the pressure off the compressed nerve root. And as long as there's no instability, you don't have to put an implant in, you don't have to do anything sexy. It's straightforward. And over time, if the spine continues to degenerate and collapse, then it may re-stenose again. So 70% of the time, it's a durable procedure. But as we age and we develop deformities, that's the other 30% because you will have collapse, you'll have a scoliosis, you'll have a slippage. So it may be a problem. And this is just an example of that little device. You can see when they flex, it sort of and extends, it sort of opens it up. It's not that popular anymore. It was really popular about 10 years ago. So if people say, well, listen, my relative is miserable, I got to do something, like, what is the outcome? And as I said before, 70 to 80% of the time, people do great and that function is preserved. And again, only fuse if you have to for instability. And over 10, 15, 20, 30 years, how many times does someone have to come back? And the answer is it's anywhere between 11 and 19% that you may have to come back to have further work done because you may re-stenose. So I've done decompression procedures in 1994. I've come back and it looks like it didn't even operate because bone is sort of grown in from the side. So it can re-stenose. So before we started to do really well-controlled level one controlled prospective randomized studies, the literature basically said surgery is probably more effective than non-operative care for people who are miserable. But that wasn't enough. That wasn't enough for people who are scientists. That wasn't enough for those who study their outcomes, and that was certainly not enough for the federal government or the insurance companies. So we all got together. We all participated in something called the SPORT study, where we looked at spinal stenosis, disc herniations, degenerative scoliosis. We looked at randomized controlled studies. And what these studies showed, and it's interesting, there was an observational group, and those are people that said, listen, I'm miserable. I don't want to be randomized. I got to have surgery. So we looked at the outcome there. And then you had those that participated in the randomization process. So you have the randomized intent to treat group, and then you have the as treated group, which is interesting. So, and what we found basically over time is those people randomized to the medical group, like non-operative treatment, 43% of them, if they were symptomatic, they said, listen, I can't handle this. They went to the surgical group. So the as treated group did so much better than the observational or randomized to non-surgical group. At 4 years, that was maintained. And then at 8 years, the randomized group sort of evened out with the non-operative group so that the results were the same. But those patients that really wanted surgery, that's the as treated group, did better than those that didn't have surgery. And this is the 4 year results, and then and Lurie and Spine published. So this is the most robust data that says if you're miserable and you want to have surgery, and you choose surgery, 8 to 10 years out, you're going to be happy, which is what you want to do. And if you look at the other studies at the time, the main lumbar spine study, they looked at an 8 to 10 year follow-up, and they found that the leg pain relief and back pain relief was better. Now, that's an interesting thing. I always tell people, don't operate for back pain because we don't understand back pain. But if someone has neurogenic claudication and back pain, 50% of the time their back pain gets better. Just like a disc herniation, 50% of the time their back pain gets better, which is interesting. So low back pain frequency and their bothersome score improved, the leg pain improved, and all the functional outcomes improved, which is great. And if you look at the Medicare database on those that have reoperations within 4 years, and this is all the Medicare data, 31,000 people, between 10 and 13% will end up going back to an operating room, either from instability because they probably should have had a fusion, or they develop junctional stenosis above and below the level. Now, once you operate, we get them out of bed that night. We make a move, make a move, we make a move. And walking, cycling, treadmill is fantastic. I'm not a big fan of braces. Even if I do a fusion in an elderly, I give it to them for 10 weeks for comfort. But if they don't want to use it, I don't really care because I think it deconditions the muscles. Not a big fan, but I use it. People always ask me, like, what's the emerging technology? Well, I would love to have like a Star Trek thing where I don't have to operate. That would be a great emerging technology, but we don't have it. But we're just making incisions smaller. We're using robots now. We're using endoscopes now. We're using tubes now. So I'm a big robot user. So I like really, really, really precise. Now remember, these aren't autonomous robots. These are robots that take us where we have to go, like through a small little incision, right down to where we have to be, so we could focus our surgical intervention. And then some people are coming up with motion sparing devices. Like if you have an instability, don't do a fusion, do a device that moves. It's in the early stages, but that's sort of the new thing. So again, the takeaways are someone has mild to moderate symptoms, always start with non-surgical treatment, avoid narcotics, work on physical therapy, work on core strengthening, work on flexion exercises. And then if they're miserable, surgery is a great option. And always do the most minimally invasive procedure possible. And if a surgeon says I'm an open surgeon, I'm okay. As long as they preserve the anatomy. You can make, I don't care what the incision looks like. It's what do you do to the spine? Undercut, preserve anatomy, preserve the joint. So that's my talk. My talks are always quick and right to the point. So I'm going to open it up for anyone with any questions.
Thank you, Dr. Vaccaro. Can you hear me?
Yeah, I can hear you now.
Perfect. All right, we had some questions come in. P please feel free to continue entering them, and I'll ask Dr. Vaccaro. So, first question is, does spinal stenosis cause numbness on the bottom or sole of one foot, or could it?
Okay, yeah, so it can. You can have unilateral symptoms with spinal stenosis. You would think if it's circumferential stenosis, but I've seen people with circumferential stenosis where their right side bothered them and the left side didn't. I always decompress both because all you need to do is just go in the operating room, do a minimally invasive procedure on one side, and then guess what? 3 months later, they're like, oh, my other side hurts. So if someone comes with circumferential stenosis and unilateral symptoms, it can cause that. It doesn't have to be bilateral. It's more common bilateral, but it doesn't have to be. And I decompress one side only. So yes, you can have it. And in that distribution, that's an S1 distribution when it's on the bottom of the foot or the side of the foot.
And thank you. Someone said their legs hurt when they cough or sneeze, and they've been diagnosed with stenosis of L4, L5. Is that a common symptom?
Well, if you Valsalva, which means you increase your intra-abdominal pressure, you increase the venous system, the vats and plexus. So yes, if you cough, if you have a valve, if you go to defecate, if you push to urinate, that increases your intra-abdominal, which transfers to the Batson valveless veins within the spine. And if you have stenosis, it can definitely cause that.
Okay. If someone has classic symptoms and has a one-level laminectomy that doesn't result in improvement, can they have a second level done without a fusion?
Okay, so repeat that one more time.
If someone has classic symptoms and has a one-level laminectomy that doesn't result in improvement, can they have a second level done without a fusion?
Yeah, yeah. You don't have to fuse. If you just had a decompression done, you can go back and decompress the second level. You don't need a fusion. The only time you want to do a fusion is if you have instability. Now, some people who have a fusion then have a decompression above it. There's a chance now, and I look at the literature. So I look at a accumulation of 30, 40, 50,000 patients. They tend to develop instability without a fusion. So you can have it, but you may slip and develop a deformity. So it may be a problem. So keep that in the back of your mind.
Thank you. What do you think of electrical nerve stimulation to help?
I think it's a great non-operative tool. All those little things for non-operative tools you could try before surgery. Anything that I don't see an obvious risk to a patient, I'm supportive of. So electrical stimulation, I don't know many risks. So you just have to look at the expense, who's paying for it. But I don't know anything that really bad can happen from it, so I'm okay with it.
Okay, thank you. This person says they were referred to a spine surgeon. The surgeon wanted to fuse and install hardware in several vertebrae in their lumbar spine. While they were waiting for the surgery, they fell a few times, and then they had to go to the ER. And the general surgeon said that they only needed a laminectomy, and they did have that laminectomy, and it was a success. So they're curious why the other doctor would tell them they needed such a severe surgery if it was not, would it be required?
Well, two things. Number one, it's hard to say who was right because you have to see over time if it does well. If you do the wrong operation, you could feel better for a while, but over time it may not be durable. So number one, until we see the films, we can't really give an opinion. But it's just another example of getting a second opinion. So if someone said no and someone said yes, then you want to adjudicate it by going back to the person who said to do something different. In this particular situation, there was no option to adjudicate because the patient was captured in an emergency room. So there was sort of couldn't go anywhere. So I can't tell you who was right. Only time will tell.
Thank you. Thoughts on the intercept procedure?
I'm a big fan if you have back pain because we don't really understand back pain. I'm a big fan. The complications are so minimal. I refer people for Intercept all the time.
Okay, thank you. Next question. Are you limiting surgery to the age of the patient? No other health issues, good partial oxygen pressure, no high blood pressure.
Yeah, I think if you're healthy, you can proceed with surgery. I'm okay with that. If you're not doing well, um, I mean, if you're healthy, I think you can proceed with surgery. I've done decompressor procedures in patients 85, 87, 88. I mean, I've done surgery on a 9-year-old. I mean, if you're screaming in pain and you're miserable, the family will ask you to do surgery. And what you want to do is, I have these three tenets. Safety is number one, efficiency is number two. You have to be an efficient surgeon, uh, which means you have to practice it and practice it and practice it, and you got to be safe. So it's minimize the time under anesthesia, minimize the amount of work you have to do, as small a procedure as possible to accomplish your goals. So as long as they're healthy and they can tolerate anesthesia, I'm okay.
Okay, thank you. Sounds like stenosis with spondy is considered instability. Is that correct?
Yeah, spondylolisthesis, yes, and in the vast majority of those cases, you should probably consider fusing in the vast majority. Sometimes it's bone on bone, it's not moving, then you don't have to do it. But I do a lot of revision surgeries. Like a lot of people say, I don't want a fusion, and they have it, and then they're miserable. And then it's hard to get them back to their baseline because when I revise a spondylo that wasn't fused, they feel better, but they never feel great. So if you have instability, it's probably, and most of the literature supports that. You should probably stabilize it.
Thank you. A couple questions about the mild procedure. What is it? Do you like it? Do you perform it? And what is the success rate?
Yeah, so mild is not performed by spine surgeons. It's performed by non-operative surgeons, and it's like putting a wire through a frame, and so you just kind of go back and forth, sort of open it up. Again, you have to look at the literature to see. So I don't do it, uh, so I really can't comment on it. It's like everyone sort of migrates to the most minimally invasive procedure. So that's extremely minimally invasive. So what you have to do is you have to say to the person doing it, I have pressure on a nerve, cannot reliably take all the pressure on my nerve off. And if you believe that that procedure can do that, then that's a consideration. But spine surgeons don't do that procedure. It's done by non-operative surgeons like physiatrists and anesthesiologists.
Okay, thank you. Next question. If there's a multi-level stenosis, for example, L3 to S1 with instability on L4 and L5, what is the best procedure?
I would only stabilize 4 or 5. I'm a minimalist, so I could do an L1 to S1 decompression. I only stabilize one level in that situation. Always do the smallest procedure. Patients appreciate it.
Thank you. What is the likelihood of stroke after spinal stenosis surgery? This just happened to a friend.
It can happen. That's why you have to have a medical evaluation. So if you have any risk factors, you have to be analyzed, and they have a risk score that they give the patient. They can say, listen, due to your cardiac health, blah, 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 your chance of an adverse event is this. The surgeon's not going to know it. It's the medical doctor. So whatever medical doctor evaluates, we'll do a cardiac slash stroke risk assessment. So as you get older, that's the problem. It's, 65, 75, 85. That's always a risk. It's rare, but it can happen.
Thank you. What is the percentage of people who, after getting cages and a fusion, the levels above can then collapse?
30% of the time, you can develop radiographic changes over 10 years at the level above. Doesn't mean you're symptomatic. It's 2.8% per year. It maxes out at 30%.
Okay, thank you. This person said they're fused from T10 through S1. This leaves me with back pain at times. They walk a lot, but they end up leaning forward and keep trying to stand up. How can they learn to walk straight?
Well, you have to do PT, 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 and then you have to find out from the surgeon, are you out of balance? And is your sagittal alignment or your SVA greater than 4 centimeters? So you have to figure out, can you stand up straight? Number one, by getting scoliosis x-rays. And then if you can, then you have to work on your extensor muscles to stand up straight.
Okay, thank you. When symptoms stop on their own, for example, no leg pain, what is the long-term prognosis? Will pain show up again? And if so, when can that usually happen?
It's hard to tell. I hope that most people that get better don't have a recurrence. So that's a great question to ask. I would say 80% of the time s- someone is having back pain. I mean, we all have back pain. I think in my life, and I haven't, I think I've gotten one lumbar spine MRI. I was miserable past, but I'd say once every 2 or 3 years, I'm miserable because of back pain. So I wouldn't be worried about it. We're getting older, so it's going to happen. Um, you just don't want to get older to the point, you don't want to become symptomatic to the point where you need surgery. If I see people who are really miserable and they have leg pain, if it happens one, two, three, like it happens 3 times, I always tell them you should probably do something so it doesn't come back. It doesn't have to come back, but everyone has back pain, so it's not that unusual. It happens.
Thank you. I know you talked a little bit about simulators, but this person said, would a spinal stimulator be possible option before doing surgery? This person said they have lumbar stenosis, degenerative discs, arthritis, bone spurs. Would that help?
Yeah, I would never ever do a spinal cord stimulator if I had spinal stenosis and I thought my legs can get better by taking the pressure off. I think that's foolish. I think that you should take the pressure off and you should reserve a spinal stimulator if you're still kind of miserable because the nerves are damaged and there's nothing objective that can be done about it. That's the best situation for a spinal stimulator. When people have stenosis or instability, and if you fix that, they'll feel better. I wouldn't get a stimulator because you're just going to be crushing the nerves, and it's not in that patient's best interest over time.
Okay, thank you. There's a few questions about laminectomies. Typical recovery of a laminectomy. Are there any restrictions after the surgery?
Yeah, so what I do in a laminectomy, you're miserable for 1 to 3 days, uncomfortable for about a week and a half. I let people go back to work at the end of a week if they have a non-labor position. If they have a labor position, it's usually 3 to 4 months. At 3 months, I let them do anything unless they want to do something that has high torque to their back, such as golf or tennis, and I say 5 months for that.
Okay, thank you. There's a lot of questions though. Just trying to go through them. Is therapeutic massage effective for stenosis?
What type of like therapeutic massage?
Yes.
Yeah, I'm a big fan of. I love massages. I think it's great. Unfortunately, it doesn't last long. It's like you feel great when you have it, and then it kind of goes away. But yeah, go for it. If you could afford it, if your partner will do it for you for free, that's even better. But I'm a big fan.
Okay, thank you. This person said they had a bilateral partial laminectomy, L2 and 3 in 2017, and they've had numbness since that time. Is there anything that can be done to improve this?
Yeah, you can take medication through like a physiatrist or an anesthesiologist. So that's called neuropathic pain, especially if there's no further stenosis. But you can modify those symptoms with medicinal treatment, gabapentin, and so forth. You can do that.
Okay, thank you. Let's see. A lot of good questions here. Um, Someone asked if you can speak to, you mentioned robotic surgery, if you could speak to robotic surgery versus, I guess, regular surgery.
Well, I'm a major fan of robotic surgery. I did it today. I'm in the operating room right now. I just love the technology. It minimizes the radiation exposure. It's more precise. I think it came out, I don't know, 7 to 9 years ago. I started to use it right away. So every week I use it. Uh, I can do really complex things to a stab wound. Like that's how big the incision is to put a screw in. I mean, it sees for you, and it texts, and I think it's great in terms of its precision.
Hi, thank you. This person said their problem sounds the opposite to the described condition where sitting provides relief. They have sciatic pain from sitting or lying down, most painful in the morning until they're up and active for a couple hours and they take meloxicam. The pain shifts from one side to the other. Would fusion be a good option?
Well, again, yeah, I have to see what the films look like. I have to see if there's instability. I have to see what's going on. If you have night pain, you have to evaluate to make sure, like, what's going on. Like, it's because it's not usual to have night pain, like you just said. So you just make sure nothing weird is going on. Get a full checkup. If nothing weird's going on, then you need a full workup to see if you have instability, a deformity, a spondylolisthesis, and then you may need an intervention. So that requires an assessment of all the imaging studies.
Okay, thank you. This person said they have lower back pain, L3, L4, L5, no leg pain. They were told that surgery wouldn't be done without leg pain. Is radiofrequency ablation in the facet joints a good alternative?
I love RFA. If you have back pain, it could be facet mediated. Sometimes it's disc mediated, but it's one of those things like Intracept. I haven't seen really bad complications from it. I'm sure everything can have a complication, but it's so minimal. I'm supportive of RFA.
Okay, thank you. Next question. With intensifying neurogenic claudication limiting distance walking, can PT and exercise really impact this and limit weakness, neuropathy, balance losses?
Right. If it's just neurogenic claudication from lumbar stenosis, I would say 70-80% of the time you're going to do really well with PT, range of motion, flexibility, strengthening, stretching, intermittent anti-inflammatories. You're going to do well. And if you don't do well, then you have to see a surgeon to talk about other solutions.
Okay, thank you. This person said they had an epidural um, in L4 and L5. They've stenosis a few years ago, but the relief was short-lived. Should they consider trying another epidural or something
Yeah,
else?
if they're having pain over an extended period of time, like more than 3 months, and the pain came back, I would tend to consider taking the pressure off so you don't go through the same process again. But if you're not miserable, I would do an epidural. If you're miserable and the pain came back again, I tend to fix things. If it's, you go to the right surgeon who can do it safely. Why go through a series of injections and just being unhappy if you had symptoms that just don't seem to go away?
Thank you. Can a disc allograft improve spinal stenosis symptoms?
I don't know what that means, a disc allograft. I don't know what that is.
Not sure.
Yeah, I don't know what that is.
What do you think of CBD therapy for pain?
I'm supportive. It's another non-addictive. Uh, I think it's not addictive. I think it doesn't have THC in it. So I think I'm not an expert, but a lot of my patients use it and they love it. So if it makes you feel good, I'm supportive. I always look into everything. What are the complications with that medication? I haven't really heard anything bad with CBD, so I'm supportive of it.
Okay, on medication, someone asked about what are your thoughts on tramadol for back pain?
Tramadol is Ultram and it has significant potential side effects. So it's a very weak addictive narcotic. So that's a negative. And it also has liver toxicities, which is a negative. I use it once in a while when patients request it, but you got to be careful with tramadol.
Okay, thank you. Someone asked, is yoga helpful for neurogenic symptoms? Are there certain postures that you should avoid?
Yeah, yoga's great. A lot of my patients love it. Any type of flexion maneuvers makes you feel better. Extension is probably what you should avoid because it'll exacerbate the symptoms.
Okay, thank you. Um, if you've had cortisone shots, nerve block, and spinal stimulation, is surgery your next option to relieve pain if you have leg pain?
Yeah, I mean, I would go through this is what I would do. I would do the physical therapy. I would do the core strengthening. I would do the anti-inflammatories. I would do Tylenol. Then you have to make a choice then. Do you want surgery? Like a lot of people don't want steroid injections because it doesn't change the anatomy. But if you want them, you do that. If that didn't work, then I would definitely do surgery before I would do a stimulator because a stimulator should be used only if you fail surgery. I think it's foolish to stick that in a narrow canal because you can cause injury to the nerves because it's not that much space to begin with. So I wouldn't do a stimulator. I would take the pressure off.
Okay, thank you. We have time for a couple more questions, Dr. Vaccaro.
Sure.
More? Okay. Just reading through these. A couple of these are a little too specific, so I apologize if we don't, if they're a little too specific to your case, that would Dr. Vaccaro may not be able to answer that. So that may require a consult. So we'll just keep these a little bit general. Give me one second. Let's see. Okay. This person said they have pain in one leg after slumping in a chair, but no back pain. It goes away if they lean forward. They've had an S1 epidural, and they're scheduling a second in a different one. What is the probability of success?
I would say 60%, 60 to 70%.
Okay. Thank you. Sorry, just going through here. Okay. This person said they've had 3 surgeries. They've had a laminectomy with good results. Second surgery was in February for a disc problem. But so far they still have a pain level of 3 to 5. They're an active 82-year-old. Should they have it looked at again? They really like to play golf.
Yeah, yeah, go back to the surgeon, find out what's going on. Have it checked out. Sometimes it's just arthritis and you can't do anything about it. But I'd go back to the surgeon and say, is there anything else that you could do for me?
Thank you. Yeah.
Nat, you okay, Nat?
Yeah, sorry, I'm just going through these. There's quite a few. Seeing if
Okay.
there's anything we can little them a little bit too specific. Um, Someone asked about swimming. Is the rotation of swimming a helpful way to maintain strength and flexibility?
It is fantastic. The problem with swimming is it sometimes bothers your neck and your shoulders. That's what I see the most complaints about, but I think it's fantastic. You could swim every day. Great. Just don't do a flip at the end of the pool and hit your head. And the easiest is having a snorkel so you have to turn your neck as you get older. But swimming is great.
Okay, thank you. This person says they have spondylolisthesis with difficulty sleeping, taking gabapentin at night, lower back pain with pain in both lower legs and their feet. They're doing PT to be able to walk. What type of surgery may help with this?
I would do a minimally invasive decompression, and if there's a spondylolisthesis, you may need to have it fused.
Yeah. All right. Um, Again, some of these questions are a little specific, so we're thinking, I'm looking for some general ones. What do you think? What do you think of using an inversion table to alleviate lower back pain symptoms?
I'm a big fan. I mean, if you can afford it, do it. If you can't afford it, don't worry about it. Because all the studies have shown it doesn't have any long-term relief, but people love it. So I'm okay with it. If you have the money, if you have the inversion table, enjoy.
Okay. All right, one more. Are there any promising treatments or dietary supplements to reverse degeneration?
Not yet, there isn't. We're always experimenting with stem cell and all that stuff, but nothing out there yet.
All right. All
All
right.
right, guys. Everyone have a nice day.
Thank you so much. Everyone, we did record this, so I will be sending it out to everyone um, who logged on
Hey,
and then
bud.
wasn't able to join. So
What are you doing?
it out. Thanks so much for joining and have a great night.